Exocrine pancreas, gallbladder, and liver pathology. Exocrine pancreas. Annular pancreas. A developmental malformation in which the pancreas forms a ring around the duodenum, leading to a risk of duodenal obstruction. Acute pancreatitis. Inflammation and hemorrhage of the pancreas caused by autodigestion of pancreatic parenchyma by pancreatic enzymes. Premature activation of trypsin leads to activation of other pancreatic enzymes, resulting in liquefactive hemorrhagic necrosis of the pancreas and fat necrosis of the peripancreatic fat. The most common causes are alcohol use and gallstones, while other causes include trauma, hypercalcemia, hyperlipidemia, drugs, scorpion stings, mumps, and rupture of a posterior duodenal ulcer. Clinical features include epigastric abdominal pain radiating to the back, nausea, vomiting, periumbilical and flank hemorrhage due to necrosis spreading into the periumbilical soft tissue and retroperitoneum. Elevated serum lipase and amylase levels, with lipase being more specific, and hypocalcemia due to calcium consumption during fat necrosis. Complications include shock caused by peripancreatic hemorrhage and fluid sequestration. Pancreatic pseudosis formation by fibrous tissue surrounding liquefactive necrosis and pancreatic enzymes, presenting as an abdominal mass with persistently elevated amylase and risk of rupture leading to enzyme release and hemorrhage. Pancreatic abscess, often due to Escherichia coli, presenting with abdominal pain, high fever, and persistently elevated amylase, disseminated intravascular coagulation, and acute respiratory distress syndrome. Chronic pancreatitis. Fibrosis of the pancreatic parenchyma, most often secondary to recurrent episodes of acute pancreatitis. The most common causes are chronic alcohol use in adults and cystic fibrosis in children, though many cases are idiopathic. Clinical features include epigastric abdominal pain radiating to the back, pancreatic insufficiency leading to malabsorption with steatorrhea and deficiency of fat-soluble vitamins. Amylase and lipase are not useful serologic markers in chronic pancreatitis. Dystrophic calcification of pancreatic parenchyma may be seen on imaging, and contrast studies show a chain of lakes appearance due to dilated pancreatic ducts. Late complications include secondary diabetes mellitus due to destruction of islets and increased risk of pancreatic carcinoma. Pancreatic carcinoma. Adenocarcinoma arising from the pancreatic ducts, most commonly seen in the elderly with an average age of 70 years. Major risk factors include cigarette smoking and chronic pancreatitis. Clinical features typically appear late and include epigastric abdominal pain with weight loss, obstructive jaundice with pale stools, and palpable gallbladder, commonly seen in tumors arising in the head of the pancreas. Secondary diabetes mellitus seen with tumors of the body and tail, episodes of pancreatitis, and migratory thrombophlebitis, known as Trousseau sign, presenting as swelling, erythema, and tenderness in the extremities in about 10% of patients. The serum tumor marker is carbohydrate antigen 19-9. Surgical treatment involves en-bloc removal of the head and neck of the pancreas, the proximal duodenum, and the gallbladder, known as the Whipple procedure. The prognosis is very poor, with 1-year survival less than 10%. Gallbladder and biliary tract. Biliary atresia. Failure to form or early destruction of the extrahepatic biliary tree leads to biliary obstruction within the first 3 months of life. It presents with jaundice that progresses to cirrhosis. Cholelithiasis, gallstones. Solid round stones form in the gallbladder due to precipitation of cholesterol or bilirubin in bile. This arises from supersaturation of cholesterol or bilirubin, decreased phospholipids such as lecithin or bile acids that normally increase solubility or stasis. Cholesterol stones, which are yellow, are the most common type, especially in Western populations. They are usually radiolucent, though some may be radiopaque due to associated calcium. Risk factors include age in the 40s, estrogen exposure such as in females, obesity, multiple pregnancies, and oral contraceptive use, as well as clofibrate use, Native American ethnicity, Crohn's disease, and cirrhosis. Bilirubin stones, which are pigmented, are composed of bilirubin and are usually radiopaque. Risk factors include extravascular hemolysis, which increases bilirubin in bile, and biliary tract infection, such as by Escherichia coli, Ascaris lumbricoides, or Clenorchis sinensis. Ascaris lumbricoides is a common roundworm infecting up to 1/4 of the global population, particularly in regions with poor sanitation through fecal-oral transmission, and it infects the biliary tract, increasing gallstone risk. Clenorchis sinensis, the Chinese liver fluke, is endemic in China, Korea, and Vietnam, and increases the risk for gallstones, cholangitis, and cholangiocarcinoma. Gallstones are usually asymptomatic but can lead to complications such as biliary colic, acute and chronic cholecystitis, ascending cholangitis, gallstone ileus, and gallbladder carcinoma. Biliary colic. Biliary colic presents with waxing and waning right upper quadrant pain caused by the gallbladder contracting against a stone lodged in the cystic duct. Symptoms are relieved if the stone passes. Obstruction of the common bile duct may result in acute pancreatitis or obstructive jaundice. Acute cholecystitis. Acute inflammation of the gallbladder wall occurs when an impacted stone in the cystic duct causes dilation, pressure ischemia, bacterial overgrowth, typically by Escherichia coli, and inflammation. It presents with right upper quadrant pain, often radiating to the right scapula, fever with elevated white blood cell count, nausea, vomiting, and elevated serum alkaline phosphatase due to ductal injury. If untreated, there's a risk of rupture. Chronic cholecystitis. Chronic inflammation of the gallbladder is caused by chemical irritation from long-standing gallstone disease with or without episodes of acute cholecystitis. It is characterized by herniation of gallbladder mucosa into the muscular wall, forming Rokitansky-Askoff sinuses. It presents with vague, right upper quadrant pain, especially after meals. A late complication is porcelain gallbladder, a shrunken hard gallbladder due to chronic inflammation, fibrosis, and dystrophic calcification, which carries an increased risk of carcinoma. Treatment is cholecystectomy, particularly when porcelain gallbladder is present. Ascending cholangitis. Ascending cholangitis is a bacterial infection of the bile ducts, usually due to ascending infection by enteric gram-negative bacteria. It presents with sepsis characterized by high fever and chills, jaundice, and abdominal pain, with increased incidence in the presence of cholelithiasis or stones in the biliary ducts. Gallstone ileus. Gallstone ileus occurs when a gallstone enters and obstructs the small intestine, typically due to cholecystitis with fistula formation between the gallbladder and small bowel. Gallbladder carcinoma. Gallbladder carcinoma is an adenocarcinoma arising from the glandular epithelium lining the gallbladder wall. Gallstones are the major risk factor, especially when complicated by porcelain gallbladder. It classically presents as cholecystitis in an elderly woman and carries a poor prognosis. Liver. Jaundice. Jaundice is a yellow discoloration of the skin with the earliest sign being scleral icterus or yellow discoloration of the sclera. It occurs due to increased serum bilirubin, usually greater than 2.5 milligrams per deciliter, and arises from disturbances in bilirubin metabolism. Normally, red blood cells are consumed by macrophages of the reticuloendothelial system. Protoporphyrin from heme is converted to unconjugated bilirubin. Albumin carries unconjugated bilirubin to the liver, where the enzyme uridine glucuronil transferase in hepatocytes conjugates bilirubin. Conjugated bilirubin is transferred to bile canaliculi to form bile, which is stored in the gallbladder. Bile is released into the small intestine to aid digestion, and intestinal flora convert conjugated bilirubin to urobilinogen, giving stool its brown color. Some urobilinogen is reabsorbed into the blood and excreted by the kidney, giving urine its yellow color. Causes of jaundice. In extravascular hemolysis or ineffective erythropoiesis, high levels of unconjugated bilirubin overwhelm the liver's conjugating capacity. Dark urine results from increased urine urobilinogen, but unconjugated bilirubin is not water-soluble and is absent from urine. There's an increased risk of pigmented bilirubin gallstones. Physiologic jaundice of the newborn occurs because the neonatal liver has transiently low uridine glucuronil transferase activity, leading to increased unconjugated bilirubin. Since unconjugated bilirubin is fat-soluble, it can deposit in the basal ganglia, causing kernicterus, which results in neurological deficits and death. Treatment is phototherapy, which makes unconjugated bilirubin water-soluble. Gilbert syndrome is caused by mildly reduced uridine glucuronil transferase activity and is inherited in an autosomal recessive pattern. It presents with mild jaundice during stress, such as severe infection, but is otherwise not clinically significant. Crigler-Najjar syndrome is characterized by a complete absence of uridine glucuronil transferase, leading to severe unconjugated hyperbilirubinemia and kernicterus, which is usually fatal. Dubin-Johnson syndrome results from a deficiency of bilirubin canalicular transport protein and is inherited in an autosomal recessive pattern. It leads to conjugated hyperbilirubinemia and a darkly pigmented liver, but is otherwise not clinically significant. Rotor syndrome is similar but lacks liver discoloration. Biliary tract obstruction or obstructive jaundice may occur due to gallstones, pancreatic carcinoma, cholangiocarcinoma, parasites, or the liver fluke Clonorchis sinensis. It causes elevated conjugated bilirubin, decreased urine urobilinogen, and increased serum alkaline phosphatase. Clinically, it presents with dark urine due to bilirubinuria, pale stools, pruritus from increased plasma bile acids, hypercholesterolemia with xanthomas, and steatorrhea with malabsorption of fat-soluble vitamins. Viral hepatitis causes inflammation that disrupts hepatocytes and small bile ductules, leading to elevation of both conjugated and unconjugated bilirubin. Dark urine occurs due to bilirubinuria, while urine urobilinogen is normal or decreased. Hepatitis viruses. Hepatitis A virus and hepatitis E virus are transmitted by the fecal-oral route. Hepatitis A virus is commonly acquired by travelers, while hepatitis E virus is commonly acquired from contaminated water or undercooked seafood. Both cause acute hepatitis and do not progress to a chronic state. The presence of antivirus immunoglobulin M indicates active infection, while antivirus immunoglobulin G is protective and indicates prior infection or immunization, though a vaccine exists only for hepatitis A virus. Hepatitis E virus infection in pregnant women is associated with fulminant hepatitis, characterized by massive liver necrosis and liver failure. Hepatitis B virus is transmitted parenterally through childbirth, unprotected sexual contact, and intravenous drug use. It can cause acute hepatitis, and chronic disease occurs in about 20% of cases. Hepatitis C virus is transmitted parenterally, most commonly through intravenous drug use, unprotected intercourse, or needle sticks. Transmission through blood transfusion is rare due to screening. It causes acute hepatitis and progresses to chronic disease in most cases. Hepatitis C virus ribonucleic acid testing confirms infection, and decreased viral levels indicate recovery, while persistence indicates chronic disease. Hepatitis D virus is dependent on hepatitis B virus for infection. Superinfection of existing hepatitis B virus infection causes more severe disease than co-infection, which occurs when both viruses infect simultaneously. Serologic markers of hepatitis B virus. In acute infection, hepatitis B surface antigen is the first serologic marker to rise, followed by the presence of immunoglobulin M antibodies against the hepatitis B core antigen. During the window period, only immunoglobulin M anticore antibodies are present. In resolve infection, immunoglobulin G anticore and anti-surface antibodies appear, with anti-surface immunoglobulin G providing protection. Chronic infection is defined by the persistence of hepatitis B surface antigen for more than 6 months, and infectivity is indicated by the presence of hepatitis B E antigen or hepatitis B viral deoxyribonucleic acid. Immunization produces only protective immunoglobulin G against the hepatitis B surface antigen. Viral hepatitis. Viral hepatitis is inflammation of the liver parenchyma, usually caused by hepatitis viruses, though other causes include Epstein-Barr virus and cytomegalovirus. Hepatitis viruses cause acute hepatitis, which may progress to chronic hepatitis. Acute hepatitis presents with jaundice due to mixed conjugated and unconjugated bilirubin, dark urine due to conjugated bilirubin, fever, malaise, nausea, and elevated liver enzymes with alanine aminotransferase greater than aspartate aminotransferase. Inflammation involves the lobules of the liver and portal tracts and is characterized by apoptosis of hepatocytes. Some cases are asymptomatic but show elevated liver enzymes. Symptoms typically last less than 6 months. Chronic hepatitis is defined by symptoms persisting longer than 6 months. The inflammation primarily involves the portal tracts and carries a risk of progression to cirrhosis. Cirrhosis. Cirrhosis is end-stage liver damage characterized by disruption of the normal hepatic parenchyma, replaced by fibrous bands and regenerative nodules of hepatocytes. Fibrosis is mediated by stellate cells, which lie beneath the endothelial cells lining the hepatic sinusoids. Clinical features include complications of portal hypertension, such as ascites, congestive splenomegaly with hypersplenism, portosystemic shunts including esophageal varices, hemorrhoids and caput medusae, and hepatorenal syndrome, which is rapidly developing renal failure secondary to cirrhosis. Decreased detoxification leads to mental status changes, hysterexis, and coma due to increased serum ammonia, which is metabolic and reversible, as well as gynecomastia, spider angiomata, and palmar erythema due to hyperestrogenism and jaundice. Decreased protein synthesis results in hypoalbuminemia with edema and coagulopathy due to decreased synthesis of clotting factors, with a degree of deficiency monitored by prothrombin time. Alcohol-related liver disease. Alcohol-related liver disease results from damage to hepatic parenchyma caused by alcohol consumption and is the most common cause of liver disease in Western countries. Fatty liver occurs due to accumulation of fat within hepatocytes, producing a heavy, greasy liver, which resolves with abstinence from alcohol. Alcoholic hepatitis results from chemical injury to hepatocytes, commonly seen with binge drinking. Acetaldehyde, a toxic metabolite of alcohol, mediates the damage. It is characterized by swollen hepatocytes containing Mallory bodies, which are damaged cytokeratin filaments, along with necrosis and acute inflammation. Clinically, it presents with painful hepatomegaly and elevated liver enzymes with aspartate aminotransferase greater than alanine aminotransferase and may lead to death. Cirrhosis is a chronic complication of long-term alcohol-induced liver injury, occurring in about 10 to 20% of alcoholics. Non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease is characterized by fatty change, hepatitis, and sometimes cirrhosis occurring without exposure to alcohol or other known liver toxins. It is commonly associated with obesity and is a diagnosis of exclusion. Laboratory findings typically show alanine aminotransferase greater than aspartate aminotransferase. Hemochromatosis. Hemochromatosis is a disorder characterized by excess body iron leading to deposition in tissues, known as hemosiderosis, and resulting in organ damage called hemochromatosis. Tissue injury occurs due to the generation of free radicals. The condition may be due to an autosomal recessive defect in iron absorption, which is primary hemochromatosis, or may develop secondary to chronic transfusions. Primary hemochromatosis is caused by mutations in the HFE gene, most commonly the C282Y mutation, in which cysteine is replaced by tyrosine at amino acid 282. Clinical presentation typically occurs in late adulthood. The classic triad consists of cirrhosis, secondary diabetes mellitus, and bronze skin pigmentation. Other manifestations include cardiac arrhythmias and gonadal dysfunction resulting from testicular atrophy. Laboratory findings show increased ferritin, decreased total iron binding capacity, elevated serum iron, and increased percent saturation. Liver biopsy reveals accumulation of brown pigment in hepatocytes, and Prussian blue staining distinguishes iron, which appears blue, from lipofuscin. Lipofuscin is a brown pigment that represents a wear-in tear product from peroxidized lipid turnover and is commonly found in hepatocytes. Patients have an increased risk of developing hepatocellular carcinoma. Treatment involves regular phlebotomy. Wilson disease. Wilson disease is an autosomal recessive disorder caused by a defect in the ADP7B gene, leading to defective ADP-mediated hepatocyte copper transport. This defect results in reduced copper transport into bile and decreased incorporation of copper into ceruloplasmin. Copper accumulates within hepatocytes, leaks into the serum, and deposits in various tissues. Copper-induced free radical formation causes tissue damage. The disease typically presents in childhood with clinical features including cirrhosis. Neurologic symptoms such as behavioral changes, dementia, chorea, and Parkinsonian features due to copper deposition in the basal ganglia and Kaiser-Fleischer rings in the cornea. Laboratory findings show increased urinary copper, decreased serum ceruloplasmin, and increased copper on liver biopsy. There is an increased risk of hepatocellular carcinoma. Treatment is with D-penicillamine, which chelates copper for excretion. Primary biliary cirrhosis. Primary biliary cirrhosis is an autoimmune granulomatous destruction of intrahepatic bile ducts. It classically arises in middle-aged women and is associated with other autoimmune disorders. The exact etiology is unknown, but anti-mitochondrial antibodies are typically present. The disease presents with features of obstructive jaundice, and cirrhosis develops as a late complication. Primary sclerosing cholangitis. Primary sclerosing cholangitis is characterized by inflammation and fibrosis of both intrahepatic and extrahepatic bile ducts. The fibrosis shows a distinctive periductal onion skin pattern. Unaffected duct regions become dilated, producing a beaded appearance on contrast imaging. The etiology is unknown, but it is strongly associated with ulcerative colitis and is often positive for paranuclear antineutrophil cytoplasmic antibodies. Patients present with features of obstructive jaundice and cirrhosis may occur as a late complication. There's an increased risk for cholangiocarcinoma. REYE syndrome. REYE syndrome is a fulminant hepatic failure with encephalopathy that occurs in children with viral illnesses who are treated with aspirin. It is thought to result from mitochondrial damage within hepatocytes. Clinical features include hypoglycemia, elevated liver enzymes, nausea, and vomiting, which may progress to coma and death. Hepatic adenoma. Hepatic adenoma is a benign tumor of hepatocytes, commonly associated with oral contraceptive use, and typically regresses after discontinuation of the drug. There's a risk of rupture with intraperitoneal hemorrhage, especially during pregnancy, because the tumors are subcapsular and enlarge in response to estrogen. Hepatocellular carcinoma. Hepatocellular carcinoma is a malignant tumor of hepatocytes. Major risk factors include chronic hepatitis due to hepatitis B virus and hepatitis E virus, cirrhosis caused by alcohol, non-alcoholic fatty liver disease, hemochromatosis, Wilson disease, and alpha-1 antitrypsin deficiency, as well as aflatoxin exposure from Aspergillus species, which induces mutations in the p53 gene. The disease increases the risk of Budd-Chiari syndrome, characterized by hepatic vein obstruction leading to liver infarction. It presents with painful hepatomegaly and ascites. Hepatocellular carcinoma is often diagnosed late because its symptoms are masked by underlying cirrhosis, resulting in a poor prognosis. The serum tumor marker for hepatocellular carcinoma is alpha-fetoprotein. Metastasis to liver. Metastasis to the liver is more common than primary liver tumors. The most frequent primary sources include carcinomas of the colon, pancreas, lung, and breast. Metastatic disease results in multiple nodules throughout the liver and clinically presents with hepatomegaly and a nodular free edge of the liver.